center of gravity in both the vertical and horizontal axis. This results in conservation of energy during normal gait. Any interference with the normal motions, such as imposed by a brace or an arthritic joint, will result in increased energy expenditure. Width of base. With the examiner standing behind the patient, note that the normal base is from 2 to 4 inches wide. This is determined by the horizontal distance between the feet at the time of double stance or double support. Stride length and step length. The stride length is defined as the distance from the point of heel strike of one foot to the point of the heel strike of the same foot. The step length is the distance from the point of heel strike of one foot to the heel strike of the other foot. In normal gait, the stride lengths for both legs are equal, and the step lengths for both the left and the right leg will be equal. Any abnormality in the various components of the stance phase or swing phase, or in any of the other components of gait, suggests that there is pathology which should be identified by the examiner. Abnormal gait. Having an understanding of normal gait and its various components, we can now turn our attention to abnormal gait and discuss the various problems which can alter the normal gait pattern. Abnormal gait is often called a limp, but not all limps are the same, nor do they have the same causative factors. Many of the abnormalities are noted during the stance phase, because that is when the whole body weight is being supported by one lower extremity, and it is during this phase that pain, muscle weakness, and joint abnormalities will produce their predominant effect. Antalgic gait. Antalgia means against pain. In an antalgic gait, the stance phase is decreased in order to get the weight off the affected extremity. The swing phase, thus the step length of the normal extremity, may be shortened in order to get the good foot back on the ground, so that the painful extremity may be lifted from the ground or relieved of weight bearing. An antalgic gait is not specific for any pathology, and it may only represent a pebble in the shoe rather than some physical abnormality. Pain in any portion of the lower extremity that would be increased with walking would generally lead to an antalgic gait. Pain, weakness, and joint abnormalities are the main pathological conditions that give rise to abnormalities of gait. As with the discussion of normal gait, it is best to start at heel strike of the stance phase when analyzing an abnormal gait. Abnormal heel strike. Heel pain. Any painful lesion in the region of the hindfoot which would cause increased pain with contact pressure may lead to an abnormal heel strike. The patient may actually avoid the heel strike component altogether and hop onto the mid and forefoot. Quadriceps weakness. At the time of heel strike, the knee is normally in full extension. If there is quadriceps weakness, thus not allowing the patient to maintain knee extension, the patient may attempt to push on the thigh in order to extend and lock the knee. Foot flat. Prior to the foot flat component of the stance phase, the dorsiflexors of the foot and ankle, through controlled relaxation, allow the gradual smooth lowering of the foot to the ground. Foot slap gait. Weakness of the foot and ankle dorsiflexors allows the foot to slap down on the ground. This gait abnormality can be diagnosed by hearing the patient approach the office. Mid-stance. Back knee gait. Patients with a fixed plantar flexion deformity of the ankle may develop recurvatum at the knee to accommodate forward motion of the trunk and pelvis during mid-stance. Normally, the knee during the first part of mid-stance is maintained in a slightly flexed position. With weakness of the quadriceps muscle, the patient may hyperextend the knee or develop a back knee gait in order to lock the knee and prevent the knee from buckling or going into excessive flexion. Abductor lurch or gluteus medius gait. During mid-stance, the abductor muscles about the hip on the weight-bearing side must contract to prevent the opposite pelvis from tilting down excessively. This increases the pressure across the hip joint to more than that of just body weight and may result in increased pain in the presence of pathology about the hip. As Columbus was able to balance an egg on its end, theoretically one can shift their center of gravity over the hip joint and balance the body weight on top of the ball of the femoral head, thus eliminating the need for muscle contraction and reducing the total force on the hip. This results in a lateral shift of the trunk greater than 1 inch and is known as an abductor lurch or gluteus medius gait. Weakness of gluteus medius muscle activity, such as in polio or an L5 nerve root lesion, may also be compensated by using the abductor lurch. In my experience, however, where pain is not involved, the patient tends to have a Trendelenburg gait. Instead of the trunk and pelvis shifting laterally over the leg in the stance phase, in the Trendelenburg gait, the patient allows the pelvis on the opposite side, that is the swing-through side, to sink excessively below the horizontal, giving rise to the so-called Trendelenburg gait. Gluteus maximus gait. During mid-stance, the ipsilateral hip must be maintained in extension or the trunk would collapse forward. If there is weakness of the gluteus maximus muscle, the patient is required to thrust the trunk posteriorly, resulting in an extensor lurch or gluteus maximus gait. Push-off. Flat foot gait or calcaneal gait. A normal push-off or toe-off cannot be performed under conditions causing pain or rigidity in the forefoot. Rather than raising up on the toes, the whole foot is brought up from the ground, resulting in a flat foot gait or calcaneal gait. This gait abnormality is also seen in conditions causing weakness of the calf muscles, which results in the inability to push off properly. Swing phase abnormalities. Steppage gait or drop foot gait. As mentioned previously, weakness of the foot and ankle dorsiflexors results in a foot slap gait. However, if there is total paralysis of the foot and ankle dorsiflexors, the leg is brought up higher off the ground than normal by flexing the ipsilateral hip and knee so that the toes of the foot will not scrape the ground during the swing phase. This is known as the steppage gait or drop foot gait, which is the swing phase abnormality in a patient with paralysis of the foot and ankle dorsiflexors. Hip hike. Patients with a drop foot or a stiff knee may hike up the ipsilateral pelvis in order to have the foot clear the floor, and this is known as the hip hike gait. Circumduction gait. Another means of overcoming the hip hike gait or a steppage gait would be to use circumduction gait in order to swing the leg out to the side, thus allowing the foot to clear the floor. abnormal pelvic rotation. Weakness of the hip flexors on the swing phase leg will not allow adequate acceleration, and to compensate, excessive forward pelvic rotation may be used by the patient to accomplish the acceleration component of the swing-through phase. A fused hip on the stance side will not allow normal forward pelvic rotation on the side of the swing leg, and thus the step length on the swing side will be limited. Wide-based gait. Impairment of balance and coordination will widen the base to greater than the normal 2 to 4 inches, resulting in the so-called wide-based gait. This in turn will cause an excessive shift in the center of gravity, resulting in increased energy expenditure. In summary, normal gait is by and large an automatic function, and the cycle can be broken down into various components. It is essential to analyze the gait cycle in terms of the various components, and an alteration in a specific component frequently suggests the underlying pathology which has caused the abnormal gait or limp.